right, so let's get started. Thank you so much for coming out tonight. There we go. I'm Dave Merman. I'm on the Green Mountain Care Board. I'm board member. Really happy to be here. Incredibly impressed to see the turnout of community engagement right here tonight with all of you, especially with the just the insanity, the tragedy, the destruction that you all have experienced recently. This is incredible, and I think your engagement's a testament to the community and to, I hope, the commitment to making healthcare work really well in your community. So thank you. A few housekeeping things to start with. The fun stuff, fire exits. It appears there's 1, 2, well, not that one, 1, 2 from here. There were restrooms down the ramp. There was, I think, just a single restroom, and then downstairs there were more. So please feel free to use them if need be. And then if you're thirsty, there's some water and refreshments right outside the door, I believe. There is closed captioning if anybody needs it, would like it, prefers it. Probably the easiest thing to do is if you're willing to just raise your hand, we can work around and get everybody set up with it. I don't know if anybody, at any time, just grab Marissa or Daniel. Who's a couple of quick things. Susan Barrett, the executive director of the Green Mountain Care Board, she's in back. This is the final community meeting, and Susan and Daniel and Marissa and Hillary Watson, who's not here tonight, I believe, have put an incredible amount of effort into this whole series of meetings, of course, with Bruce and the Oliver Wyman team, but can't thank all of them enough for this to work. It's just been amazing. Brendan Krause from Agency of Human Services, he's our, I think we're kind of into the weeks now instead of days. Brand new director of healthcare reform, incredible experience, brings a lot to the table. I think the state should be very happy to have such a great asset who's up front. Sean Tester, CEO of NVRH, and we're happy you're here, of course. I've seen multiple other NVRH people. And then Bruce Hamry, we'll let someone else introduce Bruce, but I guess I just want to say a big thank you to Bruce while he's sitting right here next to me. I can't tell you the amount of work this individual has put into this project over the last year. It goes far beyond, I think, any contractual obligation. I think that probably got completed like in November of last year, and he's met with anybody, and he would meet with all of you if you want to meet with him and give your perspective on healthcare. I can't tell you the number of people, EMTs or a nurse or someone who I work with, say, can you just chat with this guy? You have like a really interesting perspective. And he'd meet with everyone here twice and so many people. So thank you, Bruce. Just a quick thing. A lot of people don't know what the Green Mountain Care Board is, and I must admit I had a hard time finding information about it while I was trying to get the position on the Green Mountain Care Board. So just real quick, the Green Mountain Care Board is an independent regulator. We're all appointed by the governor, the board members and the chair, and confirmed by the Senate. We have staff about 25-ish people, maybe 30. We're a little understaffed, 29, 25 to 30, 29. We are charged with overseeing hospital budget regulation, so approving, modifying, or denying hospital budgets, insurance rate review for commercial insurance. And as you can imagine, these two things are in quite a bit of conflict with each other. We also oversee accountable care organizations in the state, of which OneCare is a large one, but there are some smaller ones working in the state. And then we do some health IT projects, and then we've always had a big involvement in health reform, and that's where we get to work with Brendan. And this project was a Act 167 the legislature approved in 2022, and one of the components of this act was to allocate some funding for us to hire a consultant who's gone beyond our expectations and wildest dreams to do an analysis and a plan for hospital sustainability and really health system sustainability, and Bruce will tell you far more about that. So let's see if I have any other. I'm going to skip most of my other introductory comments about affordability, access, sustainability, and costs because I think we want to get to Bruce and your questions. I'm going to just quickly introduce Brendan Krause from AHS, who will give a few comments from AHS and the work they're doing, and then we'll pass it on.
Thanks, David. Thanks for your kind words, and I would echo Dave's thanks to this community and testament to your resilience that you're all here tonight. Thank you also to the board and to Dr. Hamry and team and to the CEO, Sean Tester, for such a nice welcome this evening. I'm also not going to say much. I just like to say what you're about to hear is obviously a lot of data and somewhat sobering in some of the cases, but also presents an opportunity for us to transform care in a way that better serves the communities in which you all live. And so, very serious issues, but understand, please, or just know that we're putting this in the context of a broader sort of suite of healthcare reform that we will be consulting with communities as well about in terms of not just hospital transition and hospital sustainability, but also primary care, addressing ancillary benefits and social determinants of health needs, and other community-based interventions. So thanks very much, and over to Sean Tester to give some words of welcome.
Okay, thank you. I don't know. Can you guys hear me okay?
We need it to
Oh, you need it for closed captioning. All right, never mind. I thought I'd get away without holding it, but I guess I can't. So first off, when we got to the point in this process where we knew we were going to have this community engagement here, my goal was to fill the room. So mission accomplished, and I want to thank all of you for that. And yes, let's clap for this community. And I think the reason why all of you are here is for the same reason why I show up to work every day, which is that we care about high quality care and access in this community. And we're so passionate about that we want to do everything we can to support it. So at the start of this process, I admit some skepticism around the process and outcomes, but I have to say that I've really appreciated working with you, Bruce. I have found this to be a very thorough and thoughtful process, and you have been really good and receptive about the feedback that we've been able to provide, and that means a lot to us. I want to take a moment and just acknowledge the moment we're in right now, because if you're like me, I live at the upper end of Red Village Road in Lindenville, kind of the epicenter of the flooding. I have neighbors who've lost their house. I'm sorry, I'm a little emotional over that. And this has been a really challenging couple of weeks and months for our community. And right now, it's so important that as we think about just not only flood recovery and helping our communities heal and support those who have lost everything, that healthcare and access to healthcare, local access to healthcare, is critically important as part of that recovery process. So I hope that as we navigate this, that we see a future for sustainability for this healthcare system and all those who need healthcare services across our entire state. So thank you for being here. Thank you for being part of the dialogue. Bruce, we're looking forward to your...
Thank you very much. Well, first, thank all of you for coming. We had to postpone this a few weeks ago, and certainly willing to postpone it again if needed. I really do have a great deal of sympathy for everything you've been through, and hopefully no more rain to come for a long, long time. But thank you again for coming. So, they're not projecting. Why aren't we projecting? We are taking a moment for electrons. Sorry.
And Bruce, can you talk closer to the microphone?
Yeah.
In the back, it's hard to hear. I think there's Wi-Fi. And I have a Wi-Fi. Let's make it a hotspot.
Okay, now you got it. All right, thank you. Is this hopefully better? So we are here this evening to report back to you in St. Johnsbury our efforts to fulfill the mandates of Act 167, which are to conduct a data-driven, patient-centered, patient-focused, community-inclusive effort to assist Vermont's hospitals to reduce inefficiency, lower or constrain costs, improve population health outcomes, reduce health inequity, and increase access to essential health services. You've heard from representatives from the Green Mountain Care Board and the Vermont Agency of Human Services. Our Oliver Wyman team is here tonight to answer your questions and to present. My name is Bruce Hammery. I am a physician with over 50 years of experience in practicing and teaching medicine in hospital and health system administration and in healthcare consulting. My colleague in this effort is Ms. Elizabeth Sutherland, a partner in the firm of West Monroe and an expert in health inequity. We have been ably assisted by Ms. Irene Way, who's here tonight, our engagement manager, and Ms. Melissa Kowalski, our senior consultant. My team and I began this journey to examine the healthcare system and hospitals in Vermont a year ago, in August of 2023. We have spoken with and listened to over 2,300 Vermonters from all 14 hospital areas within the state. I have personally visited all 14 hospitals, and as Sean told me, can attest that in January, both lanes of the interstate on the way to Newport are icy, coming and going. So I live on a mountain in Massachusetts. We get ice, but not quite that much. In this journey, we've greatly been assisted by the staff of the Green Mountain Care Board, Ms. Marissa Melamed, who's here, Ms. Hillary Watson, who's not, and many others. We've also been helped by many leaders and staff throughout the Agency of Human Services and by Mr. Mike Fisher and his staff at the Office of the Healthcare Advocate, Mr. Mike Del Trecco and his staff at the Vermont Association of Hospitals and Health Systems have been especially helpful. Another consulting firm, Mathematica, and a team led by Dr. Arkadipta Ghosh has performed many of the data analyses that we have used to develop the options for changes in care delivery. These have been presented to each hospital and its board. Now, I'll note this project started aimed at hospitals. It was very, very apparent quickly that hospitals are not in control of most of what's happening. So it rapidly expanded and became a look at the entire health ecosystem in Vermont. So this has included primary care, transportation, mental health, housing, mental health beds, a lot of things that I will not have time to go into tonight. We're trying to keep things short. They'll be too long anyway, and get your comments. So I have presented previously on June 19th to the Green Mountain Care Board on some state level recommendations, and then more recently on July 9th to the Green Mountain Care Board about some more specific health system related things. So feel free to go to those two dates on the website. Slides are there, there's more detail there. There's a lot more detail coming behind that in the final recommendations that we will begin to put together after your comments tonight. So, why are we here? Well, we want to get 4 things done. One, to report to you what you and other Vermonters have told you about your lived experience with healthcare. Second, to explain the problems facing the hospital, your community, and the state as a whole in terms of health care. Most of these are beyond the control of the hospital. We will show you what some impacts might be for your community and for the Vermont health system writ large. Third, we want to share at a high level what some options are that could be used to address the current and future projected needs for your community and the state. These will apply to many hospital communities, but not necessarily to yours. Fourth, and most importantly, we want to set the stage for your active participation as a citizen and as a community in the effort to transform healthcare in Vermont. Notice healthcare not limited to hospitals. This process will be led by the Agency of Human Services and supported by the Green Mountain Care Board. This will be the next step in fulfilling the mandate of Act 167. I would note Secretary Samuelson of the Agency of Human Services has held a meeting with the hospital directors a couple weeks ago to start this process. So this is what we heard from you last October or so in a electronic meeting. It's hard to find a doctor. It's a 50-minute drive to find my doctor. Not hard to get an appointment, but I need to drive to New Hampshire to get treatment. For 2 years during COVID, my mom didn't receive an email or phone call asking how she was. Isolation can be very detrimental. Due to my insurance, I have limited access to mental health services. Part of the reason for long wait times is there are not enough doctors. Part of the reason is that we have a lot of doctors working part-time. I would add, and they don't have enough staff to help them, is one of the things that's become quite apparent. There is misinformation in the process for choosing a Medicare plan, and I needed to change providers for mental health services, and this took way too long. This is what people from around the state have reported: lack of housing, making it hard to attract providers and impossible for patients who have nowhere to be discharged, not enough transportation, may not see a provider when I go to the urgent care clinic because of workforce shortages. Many individuals don't go to care because the premiums and out-of-pockets are too high. Getting patients home has been a challenge because hospitals sending the patients back are experiencing challenges in arranging transportation. I can no longer afford the procedures or medications. My only option is not to take my medications. Gender affirming and reproductive health access is an issue, and there needs to be greater availability. So themes about housing, transportation, cost, and affordability, the access to a physician or health care, and a number of issues not necessarily reflected here around equity in terms of language, ethnicity, gender sensitivity, and so forth. So let's set the background at a high level. All Vermont communities are facing significant challenges in healthcare access, equity, and affordability. Access and equity challenges are shown on the left, affordability challenges on the right. As noted, there's difficulty in getting primary care appointments. Talk to people who've had to look for a year to a year and a half to find a primary care doctor. And in many areas, they have a 3 to 6 month wait to see someone. Now, that's not true universally, but more common than not. Same thing with getting elective surgery scheduled. Stories about a year for an eye operation, for example. Long waits for an ambulance, both to come pick you up at home or wherever, and certainly for the hospital emergency people to get a person needing care at another hospital from their emergency room somewhere else, and a lot of issues with being able to find an ambulance crew that's available to take the patient when they need to go. And difficulty for people who live in rural areas, as most in Vermont do, to be able to get themselves to an urgent appointment. If you have something scheduled a week ahead, you can get the mover usually. But if you need to get there tomorrow, or you get taken to the emergency room and need to get home tonight, that's a problem. Affordability, and we'll show a little bit more of this, but generally there has been a major increase in insurance premium plans over the last 6 years. I know a major increase was announced a few weeks ago, also contributing clearly to increases in property taxes because of the need to provide health care for the teachers. Housing costs and healthcare costs have been going up faster than income, and there have been large increases in out-of-pocket deductibles and co-pays over the past number of years that affect everyone. Vermont hospitals and many others in the U.S., particularly in rural areas, are facing significant operational and financial challenges. These include the inability to recruit staff, whether that is due to a national shortage of physicians, nurses, or other healthcare professionals, or to a lack of affordable housing in Vermont when they can be identified. A major issue affecting small communities is the number of doctors in a specialty that must be recruited to provide an acceptable call schedule. The community must also have enough patients to support that many physicians. A call schedule is the number of nights in a week that a physician takes calls from patients or needs to go to the emergency room. 40 years ago, an acceptable call schedule was 1 night in 2. Now it is 1 night in every 4 or 5. So this means if you're looking for a cardiologist, you're generally going to have to try to find 3 or 4. And you need enough people in the area to have enough need for 3 or 4 cardiologists. And it's one of the reasons that hospitals like St. Johnsbury will share a physician with another hospital. But it's a real challenge in trying to recruit and retain physicians and other folk. And it's a problem not only in small hospitals, but also for places like UVM and Dartmouth. Many hospitals are old and need to replace their heating units, their air conditioning, an elevator, and so forth. They've not been able to make the money to do this from their patient care revenues. Some surgeries done at hospitals may be done too infrequently for the staff to maintain an adequate proficiency. Many of these require not only expertise from the surgeon, but also from the anesthesiologist, the other members of the operating room staff, and often support from an ICU or certain specialists. Supporting these teams with the staff and equipment necessary will likely require hospitals to combine some surgical and medical specialists in ways that support regional access without requiring people to travel to UVM or Dartmouth or Albany or Boston. Many hospital resources are also consumed by people who do not need the services of an acute care hospital. These individuals may be waiting for transfer to a mental health or chronic care facility. They may need a place to live or the services of a home health agency to be discharged from the hospital or from the emergency department. The hospital is not paid for these people as their care is, quote, no longer medically necessary. They also use beds and nursing time that could be used for patients who do require care in an acute hospital setting. On the financial side, the costs of the people who work in hospitals and the drugs and supplies needed to care for patients are increasing at rates higher than that at which the hospital is paid. There have also been 4 unanticipated changes in federal policy within the last 6 weeks that will either increase the cost of health care or potentially reduce access. As I've commented previously, I don't think any of these four things are in the budgets that have been submitted to the Green Mountain Care Board. One is an imposition of a tariff on all medical products produced in China. This will go from 0% this year to 7.5% next year to 25% in 2025. So this affects masks and gloves and stuff. I would note one of the presidential candidates has proposed a tariff on everything not made in the U.S. Many of our drugs come from India or France. Much of our medical equipment comes from Germany. Second, there is a requirement to increase nursing staffing in skilled nursing facilities. This is clearly needed. It's a quality issue. Nurses are in short supply, so this will increase competition for a short pool of qualified staff. Third, Medicare announced a cut in payments to doctors of 3.5%. So if physicians are employed by the hospital, the revenue from that will go down a little. It also puts a lot more pressure on the private practice folks to stay afloat, and thus this may have a general effect on access. And last, and perhaps most importantly, a cut was announced of 7.5% in payments to home health agencies. Now, my opinion, this was well intended. Congress identified that for-profit home health agencies were making a lot of money. So they said cut it 7.5%, but they used a meat cleaver. They did not exempt not-for-profit nursing homes. So the Visiting Nurse Association has taken a 7.5% pay cut. They're already having trouble paying nurses enough to keep them and retain them. So just the point here is the future is a bit unpredictable. And it probably looks worse than what I'm going to show you. I'm sorry to say that. Oops. Okay. In fiscal year 2023, 9 of the 14 hospitals in Vermont had negative operating margins. An operating margin is like the balance in your checking account. It reflects the income from patient services minus the expense of providing those services. If you include the 2 additional Vermont hospitals in the red in fiscal year 2022, 11 of the 14 hospitals in the state have recently had negative operating margins. This makes borrowing money expensive and difficult for the hospital, and the financial sustainability of the hospital problematic. So this is a widespread problem both here and in the U.S. in rural areas. I must note all hospital directors and their staffs are taking measures to address this, to reduce expense, and to find ways to deal with this. It is also true that not-for-profit health plans in Vermont are not making money. And the 2 that live in Vermont, Blue Cross and MVP, are both not-for-profit. They are tightly regulated, and their premium increases are driven by the costs of care paid on your behalf to providers, hospitals, drug companies, and others. They also have to maintain certain levels of reserves to ensure their ability to pay for the care you require, and these reserves are reaching levels that are alarmingly low. Shown here on the left are the median increase in household income in Vermont in the 5-year period from 2018 to 2022. That went up just 22%. Over that same period, hospitals requested and were approved a charge increase that was totaled about 38%. And over that same period, the cost of a individual policy on the state exchange increased 108%. And what I want to call your attention to here on the right side of this is that at 2018, the price of this product in Vermont was $474, and in Massachusetts, $456. When you look all the way to the right, in 2024, that was Vermont was $948, Massachusetts was $468. So a real increase in the discrepancy, and this is true for many of this same discrepancy is true for many of the things between Vermont and other states around the country. Okay, so how do we look at this? How did we approach this? Well, I'm a doctor. We did what doctors do. We used interviews and data to make a diagnosis. We used tools and data to make a prognosis, a forecast of what the future might look like, given certain assumptions and unaltered, that is, without anybody doing anything to change this. And so I've already noted, Sean and his team and the other hospital folk around the state are working on this. AHS is working on this. Green Mountain Care Board is trying to control some things. So people are trying to address the problem. But if none of it works, we'll show you what might happen. We developed and identified treatment options. Some were drastic. All may require substantial changes. You are the patient, and you get to work with others and make the choice of treatment together with your hospital board and leadership, the Agency of Human Services, the Green Mountain Care Board, and others. So, as I noted, we listened to a lot of folk, and I guess the count has increased over the last month. It's now over 2,800. A lot of meetings, a number of different groups. These have included not only hospital leaders and boards, but also many of the healthcare professionals who serve your community. These include dentists, physical therapists, mental health counselors, doctors, nurses, pharmacists, EMTs, home health agencies, nursing home administrators, and many, many others. We have spoken with many state agencies and departments as well as legislators. We have also met with a number of community and state organizations advocating for those suffering from health inequity and those with special needs, whether those are mental health needs, physical needs, or those with specific illnesses needing more specialized care. We have sought out groups with unique language, ethnic, and gender identity characteristics. We perform tests on your community. So this is a projection of the population and its makeup in this area for through 2040. And what I want to call your attention to are three things. One is, if you look at the numbers in the top, in mainly Caledonia County, the population in 2020 was roughly 28,000. We expect that to drop by about 14% over the next 10 to 15 years. That has two implications. One, if you look at those top blue bars, those top two blue segments, the lighter blue is the elderly group, 65 to 74. And that group, you see, almost doubles, goes from 13% to about 23% of the total population. And the advanced elderly, and I may be the only one in the room in that category, because you look like a young crowd to me, but that group almost doubles. Okay, but the point here is the total number of folks over 65 goes from 20%, 1 out of 5 now, to almost 35%, okay, which is more than 1 out of 3. And as you may suspect from your elderly uncle or somebody else, older folks have different needs than younger people. So it will mean that there is more need for long-term care. And I know you had a nursing home close in the recent past. memory care, assisted living, and some other facilities, as well as older folks use more physician visits. The average, if you're between age 3 and 64, is about 3 a year. If you're over 65, it's between 10 and 11 visits a year. So the need for more primary care access goes up. The other thing that I really want to call your attention to is that dark gray bar, or that dark gray segment in the middle. It represents the working age people between age 20 and age 64 who buy commercial insurance. So this is the group that is paying those really high premiums that are then used through a variety of ways to support healthcare in the community and in the hospitals. It makes up for an underpayment. We'll get to that in a minute. But the point here is that group's going to decrease by about 20%. So the number of people able to pay those premiums is going to go down, and the number of dollars generated from those premiums is going to go down. We also did use this information and presented the data to the hospital and the board to look at cancer rates and rates of hospitalization for heart disease and stroke and that kind of thing to be used for some planning in the future. Okay. We did a physical exam to look at your systems of care. The least expensive places to receive care and to prevent the need for care in a more advanced and expensive site are shown at the top. Your house, a group home, a facility for mental health treatment, substance use treatment, skilled nursing, is considerably less expensive than down at the bottom. And when these things are not available, when you can't get to a primary care physician or a mental health person in the community or an urgent care center, you go to the emergency room. And if you've delayed care long enough and you're sicker when you get to the emergency room, you get admitted to the hospital. And if you're too sick for the local hospital, you get sent somewhere else. And the result is not only a trip, but also a pretty expensive bill and an inconvenience for the patient and her family. So, using all of this information, we constructed a financial prognosis or forecast. This makes certain assumptions, which we have tested with many people, but as Sean has noted, not everyone agrees with these exact numbers. Shown on the left in those tables are the submitted hospital charges and those approved by the Green Mountain Care Board. And you see 5-year average between 2018 and 2022. Hospital requested a 3.7% average increase. 3.2% was approved. Down below, more recently, hospital requested almost 26%, and about 19% was approved. So not everything was approved. On the graphic to the right, to the left of the gray bar, are the previous performance of the hospital, 2018 to 2022. A lot of that has COVID in it, drops in numbers of people coming, more dollars from the feds coming in, so we sort of ignored that. And we took 2023 as the base year because a lot of that had washed out. We then took two assumptions, and these are very important. One is the Green Mountain Care Board has a cap on revenue and growth of 3.5%, which represents the consumer price index plus 1%. So we use that 3.5% cap on revenue. The other then is what's the increase in cost? My guess would be 7%. There was a recent consulting report from another group that said they expected 8% next year. We talked to the hospital folk around the state. Some said, well, we think we can keep this to 5%. So this shows a 5%. Now, no surprise, your expenses are going up faster than your revenue. Things don't look good. And actually, this looks better than most of the hospitals in the state. Okay? Every hospital in the state except one is in the red by at least 3% in 2028. Okay, some of them are minus 12. If you repeat this and you do a 7% increase in costs, it gets a lot worse. Okay, now this looks at the overall state hospital revenue. And what this compares, in the light blue bar is what was submitted, and in the dark blue bar, how much was approved. If you look across the bottom, all in for these billions of dollars, virtually 100% is approved. Now, not everything for everybody every year, but when you look at the small numbers at the top, at 2013 all the way to the left, that's $2.1 billion. In 2024, the total was $3.6 billion, which is about a 74% increase. So a lot of money. Now, to put this in context, the total amount of money spent on care, all care, in the state of Vermont in 2020 was $6.4 billion. So this would be over half of it. And the statistics I saw today, I listened in on a Green Mountain Care Board set of presentations. The hospitals in the state account typically for about 52% or so of total expense. More commonly in the country, it's about 30%. And as I mentioned, insurers are losing money. This is the underwriting loss for Blue Cross Blue Shield of Vermont. Note that in the past 6 years, 5 have been losses. An underwriting loss is the amount of money that they pay out for your care that's more than the premiums they take in. And I will say I was on the board of Massachusetts Blue Cross for a few years. My hair would be whiter than it is with these numbers. And so the point here is the insurers are not going to be able to pay more without a lot more increase in premiums. They don't have reserves to pull from to continue to pay these losses. Every hospital uses the following levers to improve their operating margins and maintain financial health. They increase rates and therefore payments from insurers. As I've commented, the principal payers, the main payers for most hospitals are Medicare and Medicaid. Together, they typically account for about 80% of a hospital's revenues, maybe more in areas like this. Medicare payments are set by the federal government and only cover about 85% of a hospital's cost. Medicaid payments are set by the state legislature and the Agency of Human Services. These payments only pay about 65% of costs. In Vermont, federal matching funds make up about 70% of the total Medicare dollars paid in the state. They are dispersed through the Department of Health Access of the Agency of Human Services. Commercial insurance payments account for the remaining 15 to 20% of hospital revenue and are often used by hospitals to make up the difference between the underpayments by Medicare or Medicaid and their expenses. Hospitals may try to reduce operational expenses or cut expenses. In many instances, small hospitals do not have the capability to do this because they are already minimally staffed. And staff is one of the major drivers of expense. It accounts for 60 to 65% of all the costs of running the hospital or the people. So if you think about it, if you staff an emergency room, you have a doc, you have one or two RNs, you have some MAs, you may have a receptionist, you have an on-call radiology technician and an on-call lab technician. Doesn't matter whether you see 5 people or 35, you've got those same people that you're paying, okay? If you're at a big place, UVM or something similar, and you have 40, bays and beds in the ED, and the volume drops, you can reduce expense. You can send people home or have them work up in the main unit. But you have a much more limited capacity to reduce expense. Now, the hospital folk are trying that, right? And they're working together to take some back office functions and combine them, share certain staff. So they are working hard at this, but the opportunities are less, let me say. They can increase the volume of profitable services such as obstetrics, such as orthopedics, or I'm going there. Obstetrics is not believe me, is not a moneymaker. Although we'd like to change that, wouldn't we?
We'd love to change that. If you could just change that, we'd be happy.
We'll fix it. But like orthopedics or cardiology, and unfortunately, in extremis, they may cut unprofitable services like pediatrics or OB. And I can tell you.
We're not doing that, folks.
No, not on the table. Okay. So if you came to comment about that, you can now go. Or if none of that works, they request financial relief from the state or from a donor. So if any of you know Elon Musk, and he has a couple of $1 billion to spare, this would be the time to give his phone number to Sean. So unfortunately, pulling these levers to improve things for most Vermont hospitals has not been successful in achieving sustainable operating margins. We did made a large effort to see if addressing the problems of people who really don't have to come to the emergency room if they had a primary care doctor or could get in to see them, or if we had a place for people to go who are having to stay in the hospital because there's not a mental health bed or they don't have a home, if those things could be fixed, and people who were leaving the area to get medical care somewhere else for things that could be done here, what would happen if that were changed? And the answer is that it would help a little, but it would still not fix the major economic problem. So it might reduce the loss in 2028 from -7 to -5%, or from -17 to -15%, but it would not bring everything up to where it would really need to be. So, as I've commented, hospitals cannot solve these problems alone. Different and more innovative approaches are needed to reduce cost and improve health services in the community. And this requires concerted, sustained systems transformation, and that will be led by the Agency of Human Services and assisted by the Green Mountain Care Board. So where do we go from here? What can healthcare in Vermont look like? What will be required? What things are underway, and there are a lot, that can be built upon or enhanced? What does charting a path forward look like? First, recognize the current situation and the adverse headwinds you are facing. The Marines would term this adapt. We have discussed these. Second, change what you can and build on current efforts to change the way healthcare is delivered in your community. The Marines would call this survive. Next, design and implement ways to improve access, equity, and reduce the costs of healthcare for your community. The Marines use the term overcome for this. Done in the right way, these changes can ensure that your redesigned health services have a stable financial and operational future. Abraham Lincoln said the most reliable way to predict the future is to design it. So there are many efforts underway here. These are taken from the most recent Community Health Needs Assessment that Northeastern Vermont Medical Center and you do. And you'll note the mission and vision to the left, but then the needs that were identified as major needs here: accessible transportation, as we've talked about, timely transportation between hospitals and others, housing, which, by the way, is my number one priority for you, for the state. It's a huge issue. And being actively worked on. I need to comment. Folks are, the legislature and others are paying attention to this. Pharmacy services with the closure of some of the local pharmacies and rapid ways to get people drugs. We got some proposals for that. Some have called them Star Wars, but they're actually being done other places. Timely access to mental health, appropriately needed specialty services without travel, and local access to skilled nursing and extended care. So all the things on our list too. And here's what's underway. So the hospital has been approved for a major expansion of its emergency department and lab, and fundraising underway.
Ongoing, very successful.
So if you haven't given money, give money. They have already begun a career advancement program to grow local people and hospital employees into more skilled professional jobs. They have got, I actually was amazed when I talked to your FQHC people that they could get people in such a short time. So given my problems in getting in care down in Boston, I may take a 3.5-hour drive more often. They do have a community connections program to help people with concerns about social determinants of health, a lot of cross-coordination with other hospitals, teleneurology, and so forth, and a Rides to Wellness program. So a lot of things to build on. I'm sure a lot of other things that the Agency of Human Service and the community are doing that are not listed. So, but changes at a system level as well as a hospital level are going to be required to meet both your current needs and future healthcare needs. They fall broadly into these 5 areas: updated and modern information technology that should be available as it is in the hospital, but also in physician offices, people's homes, and other places where people receive care. Housing, as we've talked about. Some in Vermont have no house. Others are living in houses without water, electricity, or heat. This is arguably the most urgent need Vermont has, not only to address inequity, but also to provide a safe place for people to receive appropriate care outside the hospital. And just to the point, technology in the last 10 years has really progressed to the point where a lot of things that used to be done in a hospital can be done in the house. Exhibit A, you can look at your arterial blood oxygen and your EKG on this thing. When I trained in 1971, the only way you got an arterial oxygen, you put a needle in the radial artery, drew blood, sent it to the lab, and an hour later you knew how much oxygen to tune into the respirator. Now you can do it in real time in your house. So one of many opportunities to improve healthcare service and to reduce cost. Cost in the home is a lot less expensive than care in any hospital. So one of the things to think about as you plan for the future. Transportation we've talked about, and you have under consideration. One thing I would note, emergency medical services in the state are largely staffed by volunteers. They're well-trained, they work hard, but they are volunteer. And they need really to be fully funded, centralized or regionalized so that they can cover a given area, and linked to the hospital so that they can provide appropriate transportation, not always in a mobile ICU. Right? If you need to take somebody who's stable from a hospital to a nursing home, in a sense, it's going to sound weird, but in a sense, you need an SUV that'll let somebody lay down the stretcher, right? You don't need 3 guys and an IV pole and all that stuff. So there are some other ways to think about providing those services. In the planning process that is begun, but will gather steam, hospitals and communities need to design a system in which there are regional referral centers, each containing an area having a sufficient population to support the physicians, staff, equipment, and other services needed to provide high-quality, efficient care for specific diseases or conditions. Work we have done and shared with each hospital suggests that there is currently and will be sufficient need that these centers could be supported without people having to travel to UVM, Dartmouth, Albany, or Boston, or Portland, Oregon, or New York City. In the system to be developed, all providers, primary care people, specialists, dentists, EMT services, hospitals, social care providers, and so forth, should have payments linked to common goals like access, quality, efficiency, appropriate use of resources, and equity. Let me be clear about efficiency. This means doing the right thing at the right time, not forgetting to give a vaccine, and not ordering a more expensive test when another may be adequate and less expensive. So the goal is in green below. The goal is to be able to provide the most appropriate care at the most appropriate level and place in your home, in the community, or close by. There are many potential options for you, your hospital, and other hospitals in the nearby area, other communities, to plan for these changes. And we've talked a little bit about telehealth. Telehealth is used now as a way to link the emergency room folk with neurologists or cardiologists, or in one instance in the state, psychiatrists, so that people can get, the physicians locally can get some advice, the patient can get care and often not need to be transferred. It can also be used to do remote monitoring at home, or to have a patient get their follow-up care even from a distant place by visiting a site either in the primary care office or in some instances in a drugstore, that they can do telehealth with their cardiologist or dermatologist or whatever at Dartmouth or wherever they are. And this is being done, for example, in rural southwestern Virginia, which has a few more gentle rolling hills than you all do. Rural outreach. I think you have a mobile dental unit up this way, don't you, Sean?
It'll be through the FDIC, not us.
Northern Counties Healthcare has mobile dental trailers.
Okay, thank you, because I knew there was one up this way. Thank you. So, an example, other folks will put a primary care doc or a nurse practitioner in a van, be able to go out to smaller communities, hold a clinic, do mammograms, or do osteoporosis screening in rural areas. So taking the care to the person rather than having them come in. Expanding hours both for primary care and urgent care into the evenings and weekends. And I know folks have done that. Some have had to pull back because they can't provide staffing. We've talked about EMS. Availability of finding a bed for a patient at any hospital in the state. The the Agency of Human Services, the Department of Mental Health, does this now. So they know continuously who has an open mental health bed, so the emergency room folk can call one number. Now, to find a bed for a person with a physical need, they have to call the hospitals. And so what I hear from the emergency room folk is, well, I can spend 6 hours calling 19 hospitals to find a bed for a patient, and that includes Portland, Maine, I think Oregon, I guess, and Springfield, Massachusetts, and so forth. Well, you could call Springfield, Missouri, but that's where the federal prison hospital's there, by the way. But they can spend 6 hours calling hospitals. And it would be helpful if you could call one number or go to a website and at least get a sense of who to call first. Because the next issue is, once they find a bed, they have to find an EMS crew to take them there. And that can be another 4 hours. There are, I'm told, 76 separate EMS services in the state. So you have to poll them one by one. So there are some mechanistic ways to fix this that would make care more efficient and more timely. And more efficient in this sense means better care for the person. You're not sitting in an ED waiting to get somewhere. And it is also less costly. Okay, we've talked about regional stuff, regionalizing care, and mentioned that a number of the hospitals, including this one, are coordinating and collaborating to reduce some of their expenses. I will also mention that there are people in the state and everywhere who have multiple medical and mental health and physical needs. And these groups consume a very high proportion of healthcare costs. So typically about 14% of Medicaid beneficiaries are dual eligible. They have sufficient need that they get money both from Medicare and Medicaid to provide their care. Those individuals account for 30% of all Medicare dollars spent nationally and 32% of all Medicaid dollars spent nationally. So directing attention to those high needs individuals and meeting their health and social needs results in a major drop in use of emergency rooms and hospitals and other things. There are about 31,000 of those people in Vermont. There are only a couple of programs that really address them. The SASH programs do this very well, but they're pretty few in number. I think 2, maybe 3. So again, there are opportunities to do this with programs you have and other programs like PACE that are done elsewhere. Okay. So here are the major steps in designing the future for your community and your hospital. Now, back up a minute and just say there's a lot I didn't go through here. We have about 120 recommendations and options now, and we're still counting. So we did not talk about primary care, mental health, nursing homes, community health nurses, parish nurses, and on and on. We can talk about that, but we don't have 2 days. So I've limited my comments a bit. Okay, so these are the major steps. The first step is to make the decision to change. I hope this presentation and sharing of the information tonight has convinced you of this need and its urgency. In this process, you and many others will choose among the many options we will present and will construct some of your own. Those options will then need to be examined for their impact on the community and for their financial stability and viability. Planning sessions and budgets to support those options will need to be made and the plans implemented. As noted, the Agency of Human Services will lead this process, and they will gather the communities, providers, hospitals, and others desiring to plan their future and assist you through this process. There are many things going on, and we don't have time to go through all this, but this is a partial, it's not a complete list of everything that the Agency of Human Services has available to Vermonters. There are others that are at various levels of testing and implementation. Time will not permit an exhaustive review of these, but as I noted, I presented on this June 19th, and that's available for your review. I would call your attention to the large efforts directed to mental health and substance use support and to elderly care support. Major efforts are also underway to improve the infrastructure for transmitting medical data and for streamlining the licensure processes needed to get new healthcare professionals into Vermont and to allow them to practice. The Green Mountain Care Board has also had many efforts underway to constrain the increases in both medical costs and insurance premiums. These are shown here. Note that some years ago they did commission a task force on rural health services to recommend ways for improvement. And they've also been active in changing the rating and the thresholds for certificate of need process for investing in infrastructure and so forth. This effort on Act 167 has been a major initiative as well. Okay, so where do each of you go next and how do you get involved? You can attend community meetings and planning sessions. You can monitor the websites of the Green Mountain Care Board and the relevant units of the Agency of Human Services for updates and for opportunities to comment. You can provide feedback on their plans and activities. You can support the administration of Northeastern Vermont Medical Center and its board in making what may be difficult or painful choices. You can speak with your legislators and the appropriate state agencies to express the need for making the laws and funding needed to put your changes in place. Change will not happen by itself. Designing and implementing an improved, sustainable health delivery system for St. Johnsbury and the area and for other communities will require the active participation and engagement of everyone in this room, of other communities and hospitals, and of the state of Vermont. As shown by this photo of an Amish community raising a barn in Lancaster County, working together, much can be accomplished. You have many more tools available to you than the farmers in this picture. This is all handwork. Broad changes in custom and practice will be required across the state. What affects one community affects many others. An unplanned, unanticipated disaster in one community, whether it is a flood, a pandemic, or an unanticipated hospital closing, has impacts throughout Vermont. As I discussed a short time ago, the financial projections for many hospitals in the state show diminishing financial stability over the next 3 to 5 years. Therefore, your time horizon or runway to design and begin to implement change is short. The runway on the left is 10,000 feet long. The runway on the right is on the top of a mountain in Bhutan and is 900 feet long with a cliff at one end and an airplane hangar at the other. I have been to that airport. I did not fly in. There are only 8 pilots in the world qualified to fly into that, and only when it's clear. Now, your time horizon, your runway is not 900 feet, it's longer than that. But it is not 10,000 feet. I live in a small town on a mountain in Massachusetts. We argued for 5 years about whether to bring fiber optic internet to town. You don't have 5 years, okay? So the program is starting. Please be involved because it means a system change. We're not just talking about any individual hospital, but the way healthcare is organized in your community from the ground up. Okay, and there's a lot of opportunity. As I mentioned, state budget all in for healthcare a few years back was $6.4 billion. Estimates of waste in healthcare start at 30%. Now, I hope it's not 30% here, but if it's 10%, that's $640 million. Okay, you can do a lot of things with that, but it requires a thoughtful, data-driven, community-inclusive process. So that's what's about to start. And we will stop there, give this back to Sean for any comments he cares to make, and then we'll take questions and comments.
How do I follow that, Bruce? I'm not sure.
I'll tell you what. Thanks.
All right, yeah. So it's pretty sobering, huh? It's a little bit of a daunting thing ahead of us. I think, looking at, we know we have a demographic problem, we have a housing problem, we have multiple layers of systems issues within the healthcare system that are all impacting us. But what I've want us to reflect on a moment is where NVRH is today and where we've come from. So the hospital now is, I think it's 52 years old, right? And when this hospital was built, it was a 100-bed facility. Does anybody remember that? Does anybody remember Founders Hall, right? That was a real transformation of the hospital, right? To provide that services, right? When I started at NVRH about 6 years ago, most of our orthopedic work still required a hospital stay after the surgery. And today, most of the orthopedic surgeries we do are completely outpatient. You go home the same day. So we are no strangers to transformational change. We're no strangers to this. This is what we live and breathe every day. And I'm confident that we will rise to meet these challenges just like we always have. In many ways, yes, there's urgency, but we're committed to the change. And I'm confident that given our history, that we will successfully navigate it so that we're here for all of us. The way I like to think about it is NVRH is the hospital where my kids were born and where a grandmother received her end-of-life care. And my commitment to you, and I think all of our commitment, I know many of my staff are here today, is to make sure that this hospital is here for our kids' generation and their kids' generation and their kids' generation, because this community needs us. Thank you.
Thank you. So we have a microphone that we can take to you. If you have questions or comments, please. You've been very patient. Sir.
Hi, I'm Sean Hallisey. I'm from Waterford, Vermont. I was a nursing home administrator at St. Johnsbury Healthcare from 2008 to 2018. And on or about 2010, roughly, we did some of the things that you talked about. We connected with the hospital. We got the medical director, the nurse practitioner. We were able to treat people in place, which reduced costs. And I know that things change. And another company came and took over St. Johnsbury Health and Rehab. I don't know why the relationship stopped, but it was a great relationship and it worked. And I wish somehow, some way, that not just this community, but other communities in this state and in every state could repeat that model because it worked. We reduced costs by treating people for pneumonia and simple things right there. The doctor came over almost every day if we needed him. I went to the hospital and we picked up people with the bus out of the emergency room so they didn't have to linger. We admitted them. We have to work together. We have to realize about community again. And I hate to say it, but the corporation thing has really hurt America. It's driving inflation, and inflation is going to kill us long before cancer, long before heart disease. It's strangling us as a country and as a community. In 2010, there was an RN on every shift. There was an RN free float supervisor for second shift till 9 o'clock at night. Now you can't find an RN. The agency, the traveling nurse, the cost of that is driving up the cost of healthcare. It's making it very difficult to stay afloat. Another issue since I've been doing this in Vermont is, you mentioned it, they've reduced the size of the nursing homes bed-wise. We used to be 111 bed building up there. Now it's down to 70. We need to bring back the capacity. We need to educate young people to take over as nurses. We need to get doctors educated to take over so that we can reduce costs and reduce inflation. And we need to work together. I mean, we had a great program going there, and it really helped the community. And I hope someday that that can happen again when there's somebody more suitable running the health and rehab.
Thank you for your comments, sir.
Thank you.
Others, please. Yep.
I'm Susan Wells. I live in Lindenville. I work at NVRH. We are very lucky to have NVRH. I see these Stewart hospitals in Massachusetts closing, and I just think of how lucky we are to have NVRH. But I feel like something needs to change. I think something needs to change with the state. The cost of commercial insurance for the Blue Cross Blue Shield and the MVP, they're having to make up for what Medicaid pays. On a claim, what Medicaid pays based these commercial insurances is ridiculous. And people that work, the working class, can't afford these increase in premiums when the non-working are getting Medicaid, and something's got to change with that. I know a lot of patients will come in and they say, oh, I've moved here and I love Vermont. And you say, oh, what brought you here? The Medicaid, the welfare. And there's more and more of those moving here. That's fine if they have family here, but a lot of them come here because of what they hear, and we're getting more and more of those. The hospital is not going to sustain if all these people keep moving here for that, and the other people are moving away to retire. The working class, young people like my son, they don't want to come to Vermont. They have no desire to be in Vermont. So they own a PT clinic outside of Boston. There's no incentive for the young people to want to be in the working class to be here. When I retire, I'm not going to be in Vermont. So I think the state needs to change something. I know some states, if you move to a state, you have to have residency for 6 months to get Medicaid. Not in Vermont. You can get it right off. Something needs to change.
Thank you. There was another person here, I think. Oh, sorry.
Thank you. I'm Representative Terry Williams from Essex, Caledonia, and I have two questions. One is there such a thing as shopping for better pharmaceutical items? And the second question is, some of the changes is to develop a regional specialized center that meets the needs of the Northeast Kingdom. And I'm wondering what that would look like that is different than what we have today.
What was the first one about pharmaceutical? Would you, I'm sorry, ma'am, would you repeat the first question?
The first question is there such a thing as shopping around for better pharmacy products?
Yes. Thank you. Shopping around for better drug prices.
Yes.
Yes. Well, I wish there were. It's hard to do. There are states which have put some limits on pharmaceutical, the PBMs, the pharmaceutical benefits managers. And there are programs now that will produce and sell drugs at cost plus 10% or something. But I'm not aware that there is a state yet, I think California is trying, that really as a group is negotiating for drugs. I know that a number of the independent hospitals in Vermont do use a group purchasing organization to try to get to that goal. One of the federal issues is right now there's not the biologics, the new drugs for psoriasis and cancer and those kind of things are really increasing costs. There are what are called biosimilars, which are the second product another company brings to market. It's cheaper, but the regulatory process for getting those approved is lengthy. So there are some steps I think that could be taken, but I'm not aware of let's say a state that's taken on negotiating on behalf of its own people. Thank you for that question. The specialized centers thing. There are several options. As you think about it, some hospitals do a lot of orthopedics, and they don't have a urologist. Others have a urologist or a couple, they do a fair amount of urology. A number of hospitals may do minimally invasive surgery, but nobody does robotic surgery, which is used for certain procedures in a number of areas. So, and those sorts of things have expensive equipment. They generally require a team to operate, and often people will go to a large center like Dartmouth or UVM to do that, to get that care. But there are enough people within, let's say, a 3-county area where if a couple of hospitals and communities got together, they could decide one place or the other or somewhere to put up, to do that sort of work. American College of Surgery, for example, recognizes something called a Center for Acute General Surgery. So this is for people that have belly pain and fever and those sorts of things. And what the American College of Surgery says is that if you can get somebody there within 3 hours or 3 to 12 hours actually for some things, and it has a certain capability with surgeons and some GI people and a radiologist, that you can group that care. So you don't have to have necessarily a surgeon on call in every emergency room all the time. Okay, so it's things like that there's data for, people are doing, but it needs a planning process. It needs communities to be involved in those decisions. Does that help?
Yes.
Okay, thank you for the question. Other questions? I think there were a couple down here.
Hi, Bruce. Scott Beck from St. Johnsbury. I have no doubt that Sean and his team at NVRH and their healthcare partners in this area can do the reform work that you're proposing here. I mean, they've done it for decades, literally. It seems to me like the overarching headwind that's really screwing this whole thing up and making their life so difficult are just the demographics. Older, fewer people in the workforce.
Yeah.
And so my question is, the stress test you basically have done here, did you perform that stress test for different demographic trends or just that one demographic trend?
Just this one, because what you're facing. Yeah, and understand, your point's right. And there are many communities, and I'm sure here, that are trying to get new people into the workforce and change some of that demography. But no, this is the only one that we took the projection as it is. No, thanks for the question, sir.
Hi, I'm Betty Ann. I live in Lindenville. I work in human resources at the hospital. And to add on to the demographic comment, we have people who want to live here. We successfully recruit people, and they have no place to live. And so they have to decline our offers. So if there was support for reasonable, sustainable housing growth, we could make an effort at turning that demographic around. Nobody wants to see the Northeast Kingdom wither and die. We have to add housing to bring new families in.
No, thank you very much for that comment. We've heard that around the state, and it really is a problem. I mean, we've heard from a number of hospitals and communities. We've had a doc, a nurse, a radiation technologist, somebody come, spend 3 months in a hotel and leave. And the New York Times today has one of their little things about what the houses look like in different parts of the country, and they had one today in Vermont. Lovely place, 2,000 square feet, $670,000. Not too far out of Waterbury, I think. And I took the option a couple of weeks ago to my wife and I were visiting one of the areas in the state, and the only houses we could find listed, one was $1.5 million. The other was a lovely place, about 3,500 square feet, 5 acres, $5 million. So when you look at this, and when I talk to people who try to build low-income housing or build mixed-income housing, what they tell me is that they can find a developer to do it, but then they run into a 3 to 5 year process to get all the approvals. And that's both environmental and zoning. So that's one of the things that y'all have to fix. City of Houston did this a few years ago. They had a huge homeless problem. And what they identified when they went through all this was that their own rules in terms of zoning and environmental things were limiting their ability and slowing down their ability to build the housing. They fixed that. 2 years later, they had cut the number of homeless people in the city of Houston by 60%. Now, I trained in Houston many years ago. It's a big town and warm weather. There are a lot of homeless there. There were then, there are now. So it gets you to what the root cause of things are. And that's part of the planning process, because the issue that was pointed out is on target for a lot of things, because this not only applies to a house. If your hospital wants to add a mental health facility, as the folks in Bennington do, they're going to go through the same process. Okay, so it's of a piece. And it's why you look at the whole system, not just, with all due respect to the hospital, one tiny piece of it. Right? Okay, I'm sorry. Other comments or questions, please? Sir. Oh, we got to get this gentleman down here. Okay, he's next after you, please.
Hi, everybody. Caleb Grant. I'm with Rural Community Transportation, resident of Lindenville, and I don't presume to be a healthcare expert or a transportation one for that matter, but just an observation from the transportation world that relates to a comment you made about high needs individuals. When you think about transportation, everybody agrees, key element of this. But last year we gave 180,000 rides. So there is capacity there. The thing you have to look at is even covering 24% of the state's population. If you look specifically at Medicaid, 90 individuals account for 49% of our trips. So do we need to re-examine our entire system or approach, or just figure out the solution for those 90 individuals? So as it relates to your comment about high needs individuals, is it systematic change, or is it kind of acute focused rethinking how to address those individuals?
Thank you very much. Right on point. This gentleman right here, he's been very patient.
Hi, I'm Mark Tucker. I'm a NVRH corporator and recently retired school superintendent. Just a quick comment, and then I have a question for you. The comment is that a lot of what I heard you talking about tonight in your very excellent presentation has to do with capacity and the impact of being in a rural state, and that economies of scale, and you have to have enough patients to justify hiring enough staff if you can find housing for them. I've heard Sean talk about that before. So it's a similar problem with the school system, public school system in Vermont. But my question for you has to do with, and maybe this is outside of the scope of the study, or it's just one of the things that you didn't get to, but isn't there a role for reducing the number of sick people to begin with? For example, we in this country, I think we have one commentator that I listen to a lot refers to is the obesity diabetes complex that starts with processed foods and getting people overweight, and the obesity rate has gone up to something like in the 40% rate, and then those people end up as diabetics, and then they're turned over to that part of the medical care system, which is not a criticism of you guys taking care of those people, but wouldn't that help if we could figure out how to stop creating so many acute care patients that, my understanding of it, and I'm not a medical professional, is that these obese diabetic patients require a lot of care and a lot of hospitalizations. Is that a fair assessment, Sean? Did you see that a lot in the hospital? So was that part of this study at all, or is that like out of scope, or do you have any general thoughts about that?
Well, no, you raise an important point, and the state does have a number of preventive health programs. There is education about diet. Some states, some cities, Philadelphia, for example, did something fairly dramatic. They imposed a tax on any sweetened beverages, any sugared beverages, and found a pretty significant and immediate drop in consumption, and then a few years later, some changes in weight. Vermont typically, for the things that you look at in terms of a healthy community, ranks very highly, right? You've got clean air, you've got walking trails, and people who are generally active. The one difficulty with what the epidemiology people call primary prevention, lifestyle, diet, those sorts of things, is that those have a long payoff period. So, for example, smoking cessation. Somebody smokes, you get them to stop. The payoff is a decrease in lung problems and lung cancer 20 years later. Okay, but you're right, and that's being done. Those things are being done. The much more acute, high cost and access issues require a different set of approaches. But your point's well made.
Can I just
Please, sir.
I think it's a good point, and I think we also need to give a lot of credit to Vermont's healthcare system for trying to do a lot of that primary prevention. We've had the Vermont Blueprint for Health for 2 decades now. Where's Laurel Ruggles, right? How long? I mean, we have one of the, architects and champions right here in the room that was part of the NVRH team to implement that. And I think if you go back to the statistics, access to primary care in this region, we're actually pretty good. Between our partners with the FQHC, between our own practices, we really work hard to make sure that there's good access there. And that's the key. I think, though, it comes back to the demographic problem, right? And the analogy I make is, my neighbor who's a logger, 20 years ago, if he didn't have access to primary care, he's 65 years old, he died in the woods of a heart attack, right? Because his blood pressure wasn't controlled, he wasn't getting regular checkups, etc. We fixed that problem, right? We really did fix that problem. He got access to primary care. He got on meds to control his blood pressure. He maybe had help with managing, his eating habits and a little bit better on his weight. Well, now he's 85. Right? His kids have all moved away. His wife just passed away. He's alone, and he has a lot more complex problems. So that's what we're really seeing now is that the demographic curve is hitting us hard. And based on the data that Bruce has pulled together and has shared with us, that's only just going to get worse over the next 15 years.
Hi, my name is Kelsey Stavseth, and I'm the Executive Director at the Northeast Kingdom Human Services. First of all, I just want to thank you and the hospital, and just reiterate that the hospital is a cornerstone of our community. And I think I get concerned sometimes when we talk about these things and saying, what is the hospital going to do, and how are they going to fix this? And it's often about how do you reduce care. And I think Vermont is one of the lowest cost Medicare states in the country, I believe. And so, I think this is bigger than just the hospital figuring it out. And Brendan, I know you've only been here for a couple of weeks, but you're representing AHS. And I'm wondering if you could speak to how your AHS is visioning all the work that can do this. So I hear you on the acute thing. We've got our legislators here. We have our local select boards that can do zoning work. But I agree that how fast can we build housing, and then how fast can we connect the social determinants of health and other things together to solve it? I just want to be really careful about saying, what is the hospital going to do? And I think it's like, what are we going to do together? And so, one, to support the hospital because it's foundational, but what else can we all do to fix this? Because I don't think it's going to happen just at that level.
I'm sorry I was not clear enough on that point, because I've been trying to point out it's not a hospital problem, it's a community-wide systems problem. But thank you, because you're right. And that's why the planning process has to include everybody, because Sean can't sit in his office and fix this. He can't walk the floors of the hospital and fix this, right? When I came up to see him, February, I think, there was this huge line of, I still remember this, huge line of cars coming down, and the trunks popped open, and they were going around the back of the hospital, and people were getting food from the food bank. So tremendous community effort to address one of the principal causes of bad health. And to your point, exactly the sort of thing that needs to happen. The problem is that there are, in the state of Vermont, I don't know, 150, 200 towns, and every town does it a different way, right? So when Sean's a social worker or caseworker has to find a place for Bruce Hamry to get food or transportation or whatever, she's got to figure out which town I live in and how they do it. Because I've talked, for example, to people who do support care in people's homes in at least 5 different ways. Some use a community health worker, some call them a parish nurse, some call them something else, and often they are A few are funded by state funds. Often they're supported by the local church or a charitable organization. And so it's a patchwork. It's not a system, right? And that volunteerism is great, needs to be supported, but some systems need to be put together that have secure funding, that have people that work there and do that for a period of time. And that's the sort of adventure I think that you are embarked on. But just to your point, because Sean and the folk, and you know, when I was in practice, you only take care of the folks who get in to see you. And that's, you know, you spend, what, 0.2% of your life in some sort of a healthcare setting. The rest of it, you're on your own at home. So, sorry. Other questions, comments? We have, we're getting, we got 15 minutes.
Sure.
Yeah,
Very
run.
quickly, yes, I agree with everything that Bruce said. We're going to be taking a look in the next phase of this process at all of the programs that are already served in the community. So you know better than me probably what those are. You know, Blueprint and BCCI and the field services, all of those, and look to see how we can pull some of those together more closely, because you know they're different programs and they're very successful, but they're touching similar patients and serving similar needs. So we're going to try to see how we can be more efficient that way, and also leverage the data that they have, because one of the problems with addressing social determinants of health, as you may well know, is that there's not a lot of great data out there about who needs what. So so that's very much on our list. And just to give you a high level sort of approach to what we're thinking, there's this process. The next phase will be to take these recommendations and do further analysis with groups to try to understand more specifically the impact, both financially and in terms of access for the local communities. And then to begin to prioritize some of those activities. And then the next phase would be about, okay, getting on the ground and like, how do you actually do this? Like, what is the operating model and what is the financial model and what makes the most sense?
Thank you. Thank you very much. Other questions or comments? Thank you. Yeah.
Hi, my name is Lindy Medico, and I am a registered nurse at Northeastern Vermont Regional Hospital. And I wanted to speak, as I look around the room a little bit, I have a few colleagues here, and I wanted to speak just a little bit to, one, the workforce generation that I'm representing, which I'm hoping you all think is younger than I actually am, however. But in speaking to a lot of this, one thing when you, sir, I'm sorry, I forgot your name, talked about like outside of just the hospital and what are we looking at, right? I think our community does a good job. I have a mentor sitting right in front of me who is very involved in my healthcare life and my career since I was in high school. And so one of the things is, how are our schools teaching our kids, teaching our youth, teaching our people entering the workforce? How are we teaching them to navigate the healthcare system? Because they don't, a lot of them don't know. When we look at equality and disparities, a lot of the people in our younger youth groups, and I'm not usually this nervous, I'm usually pretty good in public speaking, but they don't always get a chance to get out of here, to get out of the Northeast Kingdom, to see what's out there and see what's bigger and to experience other things. And the hospital and the high schools, our local colleges, they're doing things to help people advance their careers here and to get experience. And I think it's really important that we continue to also support those. We have LNA programs. We have programs within the hospital for nurses to then go from LNA to RN to BSM and so forth. And I just want to tell you that there are a lot of us represented on the boots on the ground that are doing the work every day, working with the patients. And there's some really great things out there. And as a community, we need to support the hospital, but we also need to support our outreach programs and our programs that are looking at our younger people. We also need to recognize that, you know, the average education level in the U.S. is, I think it's 5th or 6th grade. So when we're providing education, when we're having these discussions for them to be inclusive, we need to keep those things in mind. When we're teaching people about preventative health care, right? How to take care of themselves. It starts from graded school to teach people how to take care of themselves. And there are a lot of us here that are there every day, boots on the ground, that are really committed to this. And I just wanted to put my hand up and represent those things a little bit and say, you're absolutely right. We do need to support our community as a whole. That includes the hospital, that includes mental health services, it includes our high schools, our graded schools, and the outreach that we're trying to do, and that we are trying to do it. I just went to Peacham a couple weeks ago and gave a discussion had a discussion with a great group there on heart health and how do you prevent those things. And those opportunities are out there, and access to those preventative things are out there. We just need to figure out how to best get them all the way out there.
Thank you. Sir.
Hello, Michael Acosta, CEO, Northern Counties Healthcare. Quickly, one, thank you all for being here. And two, in the Olympic spirit, just want to congratulate Bruce on his gold medal in long distance healthcare reform marathoning after 15 meetings across the state of Vermont.
It's a team effort, they say at the Olympics.
Got it. So I'll tell you one brief story. I know the hour's late. So I had the good fortune of working in public service for a long time. And that included being Deputy Director of Healthcare Reform for the state of Vermont and Deputy Commissioner of the Medicaid program. And I woke up one day and thought, I have all these opinions about healthcare, and I've never once worked for an organization that actually cares for human beings. And when I had that realization, I was like, I have to leave. I love being a public servant, but I have to leave. And so I came to Northern Counties Healthcare, which is an FQHC with primary care, dental services, and home health and hospice agency. And Cynthia Stewart and Laurel Ruggles were on the board that hired me. And it has been the most satisfying experience of my life to come out and try to work together. And in this conversation, I very much agree with Representative Beck, with Scott, and Sean. The Northeast Kingdom has got the idea that there's more to health than healthcare services for a long time. The Northeast Kingdom understands that it's going to take community effort and collaboration outside hospital walls to get things done. And so the challenge that you're laying down sounds familiar, and you should challenge us to do better and to try to lead the way and do things that could be replicated and modeled across Vermont. And so that feels really good. The one major concern I have, though, and it's just something like a pebble in my shoe as we go through this next couple of years, where I think you're exactly right, we're gonna have to deal with these issues, is that sometimes in the conversation about healthcare in Vermont, I worry that policymakers, regulators, take a look at Vermont as they wish it to be, as opposed to how it really is. Because what I learned quickly coming to Northern Counties is, I can have all the big visionary ideas about healthcare I want, but my clinics and teams need to care for people 365 days a year. You may want to move into different payment models, but when your home health nurses can't get to somebody's house because of a flood, that is the only problem that you're going to deal with that day. And so I worry, and I'll share one more story. The state of children's teeth in the Northeast Kingdom is enough to make you cry. And so lots of times we'll see kids and say, you really need to go to the pediatric dentist. And that's in Burlington, South Burlington, or Middlebury, which means they're not going. So twice we have hired pediatric dentists, and they've come up from Boston, and we pay them what they got paid in Boston, if not more. So I just worry if we make assumptions like, hey, revenue can't go more than this, and expense is gonna climb here. Sometimes we do it because we feel like that's what the community needs. So of course there's a good conversation there, and there's a balance, but I think everybody's gonna have to deal with Vermont as it really is, right? Not just how we wish it to be from a healthcare policy perspective. But Bruce, everybody, thank you so much for coming out here and chatting with us tonight.
No, thank you. No, and I think to your point, that's why it has to be very patient and community focused. Thank you.
I wasn't going to speak, but I just feel like I have to, and it is late in the hour. But I'll just simply say this. our problems in this state are housing, and everybody in this room needs to challenge their legislatures to come up with a better plan, because what the vision is, and as Michael had said, the vision is a lot different than what reality is, and it really, really is. We just went through a housing bill this year that wasn't a housing bill. It was an Act 250 strengthening bill, and that's what it did. And it put so many restrictions on housing. And it was said earlier that, well, by the presenter, that the length of time that it takes to get anything permitted is just, it's too long and it's too expensive. And it's not going to be done by government building homes. It's going to be done by private enterprise, but it is all about money. And when it takes too long to get a project through, we just had one that was done in Heinsberg, which 2 years ago we did a housing bill that we were going to build more housing, but we were going to rezone floodplains. And that's how we were going to get more housing. Well, look what happened. So that plan doesn't work anymore. But one of the programs that we did in Heinsberg, or the private enterprise did in Heinsberg, is that they went in and they developed exactly what the plan was to build in floodplain, but build it up out of it. And then the decision was made by one entity within the state that after this is going to build 103 single-family homes and 74 rentals. Everybody agreed, everybody did it, everybody done. It was done. It was all ready to go. Well, no, we can't do that. We can't build in there. So I will just simply say this. I don't care what party you're from, who you vote for, who you don't vote for, but challenge every legislator that you need housing, and it doesn't need to be an Act 250 reform bill. It needs to be a housing bill so that we can build more housing, and then we can solve the problems, because it's not just health care that housing is. We have a housing problem in the state of Vermont, and until we get real about it and get serious about it, and you challenge all your legislators to come up with a real solution, we're going to be still fighting all these problems again and again for years to come. Thank you.
Thank you. Thank you, sir. Oh, and then someone.
So just thinking out of the box a little bit, I think I recall that the hospital owns land up on Hospital Hill. Is there any way, and I know you're not in the housing business, but working with a developer and using the land to build an apartment complex to get people to come work?
We're working on it.
Good job.
No, thank you. And other hospitals around the state are doing the same thing, but it still gets to the environmental and the zoning rules. And
Those are the two big barriers. It really is the regulatory environment in the state makes it impossible for private developers. And that's got to be fixed, and I'm profoundly disappointed that there hasn't been any progress.
a last comment, perhaps? I sense a general movement to the door. All right. Listen, thank you all so much for coming and for participating.